case we're discussing today is that of a 62-year-old woman who presents with metastatic non-small cell lung cancer. So she initially presented with a cough and shortness of breath. She had imaging which revealed a mass in the right lung, as well as what was concerning for metastases in the liver. Her MRI of her brain did not reveal any metastases. She had a bronchoscopic biopsy of her lung mass as well as her mediastinal lymph nodes, and they revealed an adenocarcinoma of the lung. This tumor was then sent for molecular testing using a next-generation sequencing panel. This revealed a BRAF V600E mutation. Notably, this panel included other molecular targets which we need to look for, such as EGFR, ALK, ROS1, RET, NTRK. It was a comprehensive both mutation and translocation profile. The only alteration which was noted was BRAF V600E. The patient came in for treatment and was started on dabrafenib and trametinib. She had some nausea and vomiting, but otherwise tolerated the treatment well, and at her first scan assessment had achieved a partial response. She then continued the treatment and at 9 months follow-up had a sustained partial response. This is really a typical presentation of BRAF V600E mutant non-small cell lung cancer. Unfortunately, many patients with non-small cell lung cancer present with metastatic disease. And in this case, it's important to remember that molecular testing is essential for any patient with metastatic non-squamous non-small cell lung cancer, regardless of their smoking history or any other epidemiologic factors. And that's critical specifically for looking for BRAF mutation, because BRAF mutations, in contrast to EGFR and ALK alterations, tend to occur in patients who have a history of tobacco exposure. In this case, our patient had a 25-pack-year smoking history. Now, historically, some might have said, oh, well, we don't need to do molecular testing. We're not going to find an EGFR mutation. So first of all, that's wrong, and we should definitely be doing a comprehensive molecular test regardless of their smoking history. But it is important to note that alterations such as BRAF and MET have a higher incidence in patients with a history of tobacco exposure. So it's really important to do this sort of comprehensive molecular profiling. And when we think about that molecular profiling, it's really important that we know not only that it was done, but what test was used. Does the test look at BRAF V600E? Can the test reliably identify fusions and translocations? If it hasn't, it's not that the test is worthless, it's just it informs what further testing you may need to do in the future.